Switzerland is world famous for the outstanding quality of its watches. The Swiss pharmaceutical industry is at least just as significant, particularly the region around Basel. This is also the home of Atzino. Atzino Holding AG is headquartered in Basel, Switzerland. A total of 4 locations, 2 in Esch near Basel, 1 in Liesberg near Basel, and yet another in Germany in the city of Miesbach near Munich. Atzino develops, manufactures and sells internationally proven and innovative pharmaceuticals in advanced and refined delivery forms to other marketing and sales locations are based in Paris and Panama City. Atzino is the technology leader in the field of advanced drug delivery, with a focus on oral forms with modified release, transdermal systems, and extended release parenterals. As a partner of the pharmaceutical industry, Atzino works on a comprehensive pipeline of products for oral, transdermal, and subcutaneous administration. Atzino is a specialist in the field of complex solid forms of delivery for pellets and multiple unit pellet systems, such as MUPS tablets or microtablets. Our experts develop customized pharmaceuticals with the desired characteristics and release rates based on the specific active ingredient molecules. In addition to that, our own development department also offers seamless transfer of the development standard into the manufacture of marketable large quantities. Transdermal therapeutic patches from Atzino offer advantages over other forms of delivery by bypassing the gastrointestinal tract and thereby achieving a continuous and long-lasting concentration of the active agent in the bloodstream. We are proud to be a leading manufacturer of such therapeutic patches in Europe. Atzino implants are monolithic rods, which are about 1 to 2 centimeters long with a diameter of approximately 1 to 2 millimeters. The implant is administered subcutaneously with a dedicated applicator system. Atzino sells pharmaceuticals with proven Swiss quality under its own brand name, Atzino Switzerland. Atzino pharmaceuticals are already sold in over 80 countries. The fields of indication of the pharmaceuticals offered by Atzino Switzerland span the range from pain treatment, oncology and urology to cardiovascular and central nervous system diseases, all the way to anti-infectives and treatments for gastrointestinal disorders. In addition, Atzino Switzerland is also dedicated to the fight against malaria. Atzino Switzerland, ensuring effective relief, effectively summarizes our brand's promise. The Atzino Switzerland brand stands for the best effectiveness and safety, Swiss quality, proven active ingredients, advanced and refined drug delivery technology, and improved quality of life. After all, it is primarily the people who implement and live out this brand promise together. Each individual employee, our sales partners, doctors, pharmacists, and authorities around the globe, for the good of the patients in order to improve their quality of life. Atzino fulfills the requirement placed upon it at all levels, delivering health. Switzerland is world famous for the outstanding quality of its watches. The Swiss pharmaceutical industry is at least just as significant, particularly the region around Basel. This is also the home of Atzino. Atzino Holding AG is headquartered in Basel, Switzerland, at a total of 4 locations, 2 in Esch near Basel, 1 in Liesberg near Basel, and yet another in Germany in the city of Miesbach near Munich. Atzino develops, manufactures, and sells internationally proven and innovative pharmaceuticals in advanced and refined delivery forms to other marketing and sales locations are based in Paris and Panama City. Atzino is the technology leader in the field of advanced drug delivery, with a focus on oral forms with modified release, transdermal systems, and extended release parenterals. As a partner of the pharmaceutical industry, Atzino works on a comprehensive pipeline of products for oral, transdermal, and subcutaneous administration. Atzino is a specialist in the field of complex solid forms of delivery for pellets and multiple unit pellet systems, such as MUPS tablets or microtablets. Our experts develop customized pharmaceuticals with the desired characteristics and release rates based on the specific active ingredient molecules. In addition to that, our own development department also offers seamless transfer of the development standard into the manufacture of marketable large quantities. Transdermal therapeutic patches from Atzino offer advantages over other forms of delivery by bypassing the gastrointestinal tract and thereby achieving a continuous and long-lasting concentration of the active agent in the bloodstream. We are proud to be a leading manufacturer of such therapeutic patches in Europe. Atzino implants are monolithic rods, which are about 1 to 2 centimeters long with a diameter of approximately 1 to 2 millimeters. The implant is administered subcutaneously with a dedicated applicator system. Atzino sells pharmaceuticals with proven Swiss quality under its own brand name, Atzino Switzerland. Atzino pharmaceuticals are already sold in over 80 countries. The fields of indication of the pharmaceuticals offered by Atzino Switzerland span the range from pain treatment, oncology, and urology to cardiovascular and central nervous system diseases, all the way to anti-infectives and treatments for gastrointestinal disorders. In addition, Atzino Switzerland is also dedicated to the fight against malaria. Atzino Switzerland, ensuring effective relief, effectively summarizes our brand's promise. The Atzino Switzerland brand stands for the best effectiveness and safety, Swiss quality, proven active ingredients, advanced and refined drug delivery technology, and improved quality of life. After all, it is primarily the people who implement and live out this brand promise together. Each individual employee, our sales partners, doctors, pharmacists, and authorities around the globe, for the good of the patients in order to improve their quality of life. Atzino fulfills the requirement placed upon it at all levels, delivering health.
Good evening, everyone.
Good evening.
Before Lars address the meeting, I want to introduce colleagues with Dr. Lars. We have Salem Awad from United Arab Emirates, Salem. And we have Professor Ziad Shariha from Jordan. Ziad. We have Ahmed Hashem from Saudi Arabia. And I have other speakers with Lars. Aywa. Yes, Ziad. We have Thoufeeq from Sheffield, UK, and Mohamed Abeid from Cairo University, and Moataz from Sheffield University, and we have Younan Kabara from Cairo. Now, Professor Lars Aabakken, Oslo, Norway. Lars is very famous gastroenterologist and endoscopist from Oslo. He was the European Society of GI Endoscopy for years, then World Endoscopy for years. He's very active and he visited the Middle East many times. Lars, please start.
Well, thank you, Serag, and thank you for allowing me the honor to chair this session. Now, the introduction is made very simple by my friend who has introduced most of the key participants. I'm very excited to see how this works because obviously this format is one of the COVID situation, and I'm sure that a lot of our previous events will be replaced by variants of this. So I'll be very interested to see how this works. In terms of interaction with the audience, I think you can pose questions by chat, and maybe the host can also allow oral questions, but I think we'll come back to that. The commentators were already introduced, as were the other speakers, and maybe I'll just start by introducing myself and my little talk, which is about cholangioscopy. Is that okay? Is there anything, any household remarks from you, Serag?
Go ahead.
No?
We need the voice more clear, Lars. Either it is nearer to you or...
You cannot hear me properly?
Yeah. Yes, great.
All right, I'll lean forward. Okay, so...
Share presentation.
Yeah, so I was charged to talk a little bit about introductory endoscopy and the status of affairs in 2019. If I can make this start. Now for GI diagnostics, as you know, there has been a sequence of events in all organs in the GI tract. So initially, we had no imaging or only a surgically based image of the organs. And then piece by piece, organs were shown by radiology. And then starting in the early 60s, we got an endoluminal image. So this was the case for the stomach, where prior to radiology, we only had surgical access to the stomach. Then we had the radiology, which showed us ulcers. And then when gastroscopy came, radiology imaging of the stomach rapidly became obsolete. For the colon, it was the same thing. We had, single contrast and double contrast barium imaging. And then when colonoscopy arrived, the radiology of the colon became obsolete. For many years, the only imaging available for the small bowel was again radiology based. And then we got to the capsule endoscopy and enteroscopy. And so no wonder that the biliary tract also potentially could go through the same phases where we at the present time have been used to radiology based imaging only. So the question is, can we apply the same sequence of evolution in these organs as well? If you look at the traditional ERCP activities in most hospitals, I think 90 to 95% is about treating bile duct stone disease by cholangiography, showing the stone, doing a sphincterotomy, and then extract or destruct the stone. And then finding and stenting strictures, and also diagnosing and stenting bile duct leaks. And so for this main part of the endoscopic activity, I think the radiology imaging is perfectly fine, and there is really no need to look for an endoluminal addition to the diagnostics. But there are other unresolved aspects where ERCP with X-ray imaging is not perfect. You all, I think, experience indeterminate strictures. We have unclear filling defects where we wonder whether it's a stone, where it's an extraluminal impression, or whether it's some intraductal tumor. We have impacted and difficult stones which we cannot release by our traditional methods. We have sometimes problems deciding on ductal tumor extensions, guiding our surgeons, and sometimes we have trouble acquiring selective wire access. So all of these aspects are issues not completely resolved by the current technology. So that might be a role for intraductal optics. In the past, we did have mother-baby endoscopes, and we did have percutaneous access with various types of short scopes. And the present is based on improved mother-baby systems, direct peroral cholangioscopy, and spyglass systems. And I will go through this a little bit. So the mother-baby scopes, as you probably know, have been available since the 70s, and even my mentor in the early 80s was doing this together with his colleague. But the experience is that it's not very practical. It requires 2 operators, it's extremely expensive, it's fragile, and it was never released as commercial product. So even though it's doable, it's not something which has changed the world, I would say. Then there is direct peroral cholangioscopy, where you use a standard small caliber endoscope or a special, at least prototype-based double bending small endoscope. And then either you do a freehand cannulation pulling yourself into the bile duct, or you use a guide wire or a balloon, special balloon anchoring at the level of the liver hilum. But you do need an initial ERCP for the mapping, and also you need the normal ERCP up front to do sphincterotomy up front. And it's technically challenging. We have some experts who demonstrate this very successfully at live demos, but partially entering the bile duct may be a problem, and staying there and re-entering after pulling back is a challenge. I think the main utility of this is superb imaging. One of the experts doing this is Professor Moon, as you can see here, and he's demonstrating how he's first, through his normal duodenoscopes, placing this anchoring balloon, which can be filled with fluid, and then, as you can see, it's sort of sealed so that you can pull back your duodenoscope, leaving that balloon in place. As you can see, the hilum. This is the mechanism for sealing off the balloon, and then the small caliber scope can be introduced over that catheter, and with that kind of anchoring, which sort of is placed similar to a nasobiliary drain, you have more support and it facilitates your procedure. There are some publications on this technique, but I think they're all impaired by the fact that they're all coming from high specialty centers. But you can see that if you are an expert, then your success rate is very, very high, and even the technical success is quite high. I think, like I said, one of the main utilities is that you can utilize the optics of a normal tower, and one of the utilities of that might be the use of NBI or other filtering imaging, which might be of interest to characterize visually intraductal lesions, as you can see here. There are some unresolved issues for sure. There is a learning curve. The need for anchoring balloons has been a problem, and some other issues, as you can see. And one of the biggest concern has been the risk of air embolism, which sort of took down the enthusiasm for this technology quite a bit. I think if you're careful and aware of this risk, then you can probably reduce it quite a bit. But this technique is still not very widely used. Now, so what is more widely used is a single operator cholangioscopy system by Boston, the Spyglass system, which initially was a sort of pattern breaking technology, but with its drawbacks. So it had a very cumbersome setup. It had a visual fiber, which was quite fragile. The working channel was not perfect, and the maneuverability wasn't either. So I think all the users of this system, including myself, were extremely happy to see this expected improvement, where it's now a digital imaging. It's a simplified plug and play system. All the mounting of the fiber is gone, and the image is vastly improved as well. So I think with the introduction of this, Spyglass fundamentally came into play for the regular user as well. So for diagnostics, I think one of the most important roles is for indeterminate biliary strictures. And this is the most recent meta-analysis by the team from Florida, showing that the spy-bite biopsies in this review had a sensitivity of 60%, very high specificity, but the visual assessment was very high and actually higher than the spy-bite biopsies, which for me is a little bit strange. And I think it goes to show that many of these materials, even those going into meta-analysis, are quite diverse, and the methodology and the reporting of results is diverse as well. So I think we need more data to know exactly how good this technology is. But one of the elements that go into the visual assessment is what's called tumor vessels. So irregular widened vessels on the surface of a lesion, which is one of the most distinct features of a malignant change inside the ducts. I think also not infrequently we think that something might be a stone, but it doesn't really behave like a stone. And so this is the normal ERCP showing some lesion in the hilum. Doesn't really look like a stone here. And so we do the sphincterotomy, which is mandatory before inserting the spyglass ductoscope. But actually after you do that, introduction is quite easy. And I think already just by looking at this, you can realize this is not a stone. It does not look like a cancer. And we biopsied this lesion, and it turned out to be a stromal benign intraductal tumor. And although it was still taken out, I think it greatly helped the surgeons attacking this lesion. Something else that the surgeons are very happy to see is accurate delineation of tumors in the ducts, including Klatskin tumors. So these are completely normal ducts on the right side. And pulling back towards the hilum, you will see in a second that as soon as we look over to the left side, you will see that the tumor is very easy to delineate, and you can explain to the surgeon exactly where the tumor is and where the resection line needs to be. Similarly, you can look into the pancreas and delineate the papillary changes, as you can see on the bottom right picture. I think I'll skip that one. For therapeutics, there are two elements of that, I think. It's crushing of bile duct stones, pancreatic stones, and facilitation of stricture access. So as you know, most stones can easily be handled by balloons or mechanical lithotripsy, but in some cases that's not possible, and particularly so in in the case of impacted stones. And so if that's the case, then like you can see here, this is an impacted stone. And after introducing the spy scope, which in this case and in many cases can be done without the guide wire, because anyway you need to remove the guide wire before you do the electrohydraulic lithotripsy. You can enter the duct like this. It's also facilitated by bending the tip. Here you can see the probe directly onto the stone. You need to fill the duct with fluid, which needs to be with electrolyte, so no sterile water, but natrium chloride, and so sodium chloride. And here you can see that after some shooting, you get fragmentation of the stone. Sometimes you need to use several of these probes, and the occasional stone is too hard for this, but most of the time you can see fragmentation like this, which makes it very easy to remove the stone with a basket or a balloon later on. Same thing with pancreatic stones, but I would like to show you one more thing, because we have a lot of transplant cases, and in some cases we have, like in this case, anastomotic strictures, and probing with a guide wire doesn't really get you anywhere. It only ends up in this cystic duct remnant, as you can see. And although we have contrast going up, there's no way we can get the wire to pass into the liver. And looking at the cholangioscopy, you can see why. So here you can see the area of the anastomosis with some debris and some sutures, which is normal, and which sometimes obscures your view. But as you can see, this is where our wire went, and that's, when you look at the X-ray, that's the cystic remnant, so not really very helpful. But coming back, you will see there's another orifice down here, and that actually was the orifice going into the liver. And you can also tell that just by stochastic random probing with a wire, it's very unlikely that you would ever hit this little orifice. So by visual guiding like that, things get a lot easier. This is a case we had yesterday, and again, yeah, so it looked like this. That's again the cystic duct remnant, and I'm probing with the wire here, and you can see there is an orifice there, and the wire goes there, but without the ductoscopic access, there's no way we'd have ever been able to identify and access that orifice. There are some unresolved issues here as well. We still don't know the best indications where we can justify the cost of this single-use scope. There is a learning curve, particularly in terms of the visual diagnostics, how to interpret the visual findings. We would like, particularly in PSC patients, to understand what inflammation looks like as opposed to cancer or dysplasia. And also the utility in narrow ducts, like in the PSC patients, is less than in dilated duct because the navigational space is limited. So I think these issues still need to be resolved. But to summarize, there are several diverse technologies available now for luminal imaging, but I think the spyglass system at the moment is the most promising one. Stone therapy with EHL or laser is well established. The visual assessment of indeterminate strictures is still improving, I think. Targeted biopsies are of value, but we need improvements there as well. And the new SpyBite biopsy forceps is already being improved. Cost remains an issue, and we would like to see more players, obviously, to bring the cost down. Okay, so with that, I thank you for your attention. I don't know, Serag, do you want to take questions now or at the end, or what do you want to do? Serag? You need to unmute your mic.
I think you're muted, Prof.
مش سامعينك.
We thank you very much, Dr. Lars, for this illuminating presentation. And Ziad, Ahmed Hashem, and Salem, if you want to guide some discussion for this interesting presentation before we move to more, please.
I would like to thank Dr. Lars for this talk, but I just want to add a comment on the use of cholangioscopy in IgG4 related sclerosing cholangitis and to differentiate it from PSC, and the role of cholangioscopy in differentiating tumor from IgG4 disease, where you see more proliferative vessels in IgG4 disease. And in this disease we see now more frequent, and especially we had recently a young girl who had strictures in the biliary system, and there was bulky pancreas, although the IgG4 was normal, but we treated her because we didn't have the cholangioscopy. With oral steroids, all the strictures disappeared within 6 months. So I want your comment on this issue of IgG4 disease.
Well, I think we have a limited experience, I would say.
Yes.
And at the moment, I think we don't know enough about how to utilize the visual information that we get. Like I said, differentiating dysplasia from cancer, very hard. And differentiating inflammation from malignant changes, I think, is also hard. And I don't know about any specific findings unique to the IgG4 disease. And so at the moment, I think we do need biopsies, but I'm not sure if you can have, I mean, I don't know about the sensitivity of biopsies in IgG4 disease. And at the moment, I just think we need more experience to know more about the visual presentation of the various diseases.
Okay.
We have a question here from, I think from East Europe, Ivan Lutakov. He's asking Lars about how many ERSP you need for good learning curve to start doing oral spyglass.
How many normal ERCPs you need before you start with this?
To start doing Ductoscopy. Spyglass.
Well, first, I think that this is not equipment that should be in every hospital that does ERCP. I think at least in Norway, at the moment, it's only at the university hospitals, which are 5 in a country of 5 million people. So the center itself would have a reasonable volume before it's even reasonable to acquire the equipment. I think handling the scope does take some getting used to, because navigating the 2 different systems and handling the different wheels and knowing which screen to look at, it's a little bit confusing in the beginning. And the most typical mistake is to look at the ductal imaging and think that you can navigate by your normal wheels, and you can't. And also because you're focused on your interductal image, falling out with your duodenoscope is quite frequent, particularly because your scope gets stiffer by the presence of the ductoscope. So all of that takes some getting used to. And I would also suggest that in the beginning, even though it's called single operator system, if you have a colleague around, then having your colleague navigate your cholangioscope separate from the duodenoscope is quite practical and makes things a little bit easier.
About the cytology, do you use normal brush cytology or the metal one?
We use normal brush cytology with fish analysis when it's a question of of cholangiocarcinoma. We still do it in the context of the protocol. I think the value of fish is not too well established. I would like also to add one more thing, that if you look at the indeterminate strictures, very often these patients already were investigated, they already had a stent, and a stent in place does impact the visual aspect of the strictures. So again, we need more information how a stent phase will change the appearance of a stricture.
Any other question or comment?
Yes, please. Thank you, Dr. Lars, for this very nice presentation. Just one comment and one question. The comment is about the indication. You already stressed in your presentation about the indications, which should be really, because I witnessed this many times, that many colleagues, that they have access for spyglass, and they will go for every case with the spyglass. It is like if you have a hammer, every problem you will see will be like a nail. So the
want to get experience.
Chosen carefully, and they should always ask yourself, what consequences do I have when I do the spyglass? I witnessed many times, really not big stones. The colleagues will go for spyglass. Strictures, all strictures, they will go for spyglass. The indications should be very well chosen. The other comment is regarding the visualization, as you have just mentioned, after stenting. Do you really depend on your visualization or not? Because everything is inflamed afterwards, and most of cases will already come with a stent inside. So it is a very big question.
Yes.
The last question is the pancreas. You mentioned the IPMN, and I find it very difficult. Do we need it or not? And if yes, in which cases with IPMN?
The way we have been using it, or the cases where my surgeons ask for it, is when they, for some reason or another, want to avoid a total pancreatectomy if they can. So even if the entire duct is dilated by mucus, sometimes it's not the whole duct which is diseased. And so delineating the IPMN papillary changes in a hope to save maybe a part of the head of the pancreas is, I think, for us the only good indication. Sometimes we also see dilation where we believe it's IPMN, but we're not exactly sure. Maybe we have we don't see the mucus in the orifice. Maybe you did an aspiration and it was serous. And so also we want to verify the diagnosis prior to surgical resection.
Do you do biopsies in the pancreas or just visualization?
I think visualization is most important, because if you see the papillary protrusions, then they go for surgery anyway, and the biopsy with the very expensive spy bite will not change that decision. Okay, the last question regarding the biopsy from the spyglass. From my experience, a good biopsy with normal biopsy forceps yield more positive results as this small biopsy forceps from the spyglass. Is this also your experience, or how sensitive and specific is your biopsies with the spyglass in comparison to standard biopsy? Well, I think it depends on the location and the characteristics of your stricture. If the bottom level of the stricture, and particularly if it's abrupt and not too far from the papilla, I agree with you completely. Then going with a normal biopsy forceps alongside a guide wire is usually quite easy and gives you a much better biopsy. So we would prefer that. And I also would like to commend your commentary about the indication. And very often, or at least frequently, we have patients referred for stone therapy with the spy scope because they failed elsewhere. And we always try with a normal techniques first, including large caliber balloon dilation and mechanical lithotripsy. And very frequently, that's what we need. Thank you very much.
Okay, we have to move to the next speaker. Ahmed Hashem, introduce the next speaker, please. Hashem.
Yeah, the next speaker is...
That's me, hi.
Yes, it's Thoufeeq from Sheffield. who will talk about EMR in colonic lesions,
Thoufeeq.
I believe.
Let me see if
Thoufeeq.
I can make this play. Hi there, can you hear me and can you see the slides?
Yes.
Yes.
Excellent. Fantastic. Good evening. I think it's evening everywhere, and it's fantastic to follow Lars's fantastic talk. And I can see the interest has been fantastic based on the questions that were asked. So my topic is on colonic endoscopic mucosal resection. I'm a gastroenterologist in Sheffield, which is based in Yorkshire. And I'm also a clinical lead for endoscopy here, which is a big teaching hospital. So colonoscopy, I think, is a bread and butter for most gastroenterologists. And when you set to on your colonic journey, invariably we see polyps, and the polyps, which is basically the polyp detection rate or adenoma detection rate, can vary based on the type of the patient, type of the endoscopist, as well as the nature of the bowel prep. So it can vary between 15% to something like 70% in certain occasions. So why are polyps important? As you can see, what we're trying to do is avoid cancers or detect cancers early. And we also know that most cancers do start from polyps. And thankfully, most of these polyps take a lot of time before they become cancerous. However, it is very difficult to know exactly how long these polyps take to become cancerous. So it is quite important to detect these polyps, and also it's also very important to remove these polyps early so that we can prevent cancers. So it's important, as Lars mentioned, assessment is very important in endoscopy. Why do we do assessment? We do assessment to know what type of polyp is it? Is it cancerous, benign, or is it a adenomatous polyp? So it's important to have certain nomenclature, so you agree with certain names, so that if you're sitting in Cairo, or if you're sitting in Norway, or you're sitting in Sheffield, like the Zoom, we talk the common language. So the common language we use is the Paris classification for polyps, and that could be based on the fact that does it have a peduncle, so we can call it as a pedunculated polyp, or it has a short peduncle, so is it called as a subpedunculated polyp, or is it sessile, or then you can call it as a flat elevation, or a very, very mild flat elevation, or a depressed type of polyps. So when you're seeing a polyp, you've got several options. You can either do nothing. Doing nothing is often a very good option in life. As you said, if you have a hammer and nail, you don't have to always use them together. Then you could think about surgical resection or an endoscopic removal. This is where we are. You need to know when you're doing the polypectomy, what is the difficulty of the polyp. That is based on the size of the polyp. So the smaller the polyp, the less points it gets. The bigger the polyp, you get more points to make it more difficult. And the type of the polyp. So the flatter the polyp it is, then it becomes more difficult. And based on where the polyp is, if it is on the left side of the colon or on the right side of the colon, often the right side of the colon, the polyps tend to be more flatter or sessile. That makes it more difficult. And again, the very subjective scoring is called axis, which is basically means if it is an easy axis, you can call it as 1, and then difficult is 3. Whereas it is important that somebody's difficult, it could be someone else's easy, and someone's easy could be someone else's difficult. But the other points in the SMSA scoring system is pretty much very objective. So why is it important? We know based on the SMSA levels, we can predict the duration, how long the polypectomy is likely to take, how successful it is likely to be, what is the likelihood of recurrence, and what is the likelihood of the polyp to bleed at the time of the procedure. So this is the European Society of Gastrointestinal Endoscopy's guidance. It is a very, very, very busy slide, but I'd like you to just follow this arrow where it says, if the polyp is more than 2 centimeters, you would like to do an en bloc mucosal resection or a piecemeal resection if the en bloc is not possible. If the polyp is very big, then you think about sending the polyp to an expert. So just as what Lars mentioned, it is quite important when you're doing an endoscopy that you do an assessment. So the assessment of the polyp is very, very important. You just, based on this, you can decide on the therapy. As you can see, based on this polyp, you can see the polyp has got a stalk, and the stalk is a very short and stubby stalk. Then you can decide, do I inject the stalk? Do I use an endoloop? Do I use an endoclip? And what sort of precautions do you use? And if you think about using an endoclip, do you want to think whether you put it before you do the polypectomy, or do you want to do it afterwards? So as you can see here, we went around with using injecting the stalk of the polyp. We went to do this because the stalk is a very short stalk, so there is very limited space, if you like, to put in an envelope. So this is quite simple and easy, just to lift, put some fluid in the stalk. Whereas if you had a very long stalk, in this case, as the picture there, you would argue to say that maybe you'd like to do put an envelope or a clip at the base of the stalk. And again, there are no specific randomized multi-center trials to look at one is better than the other. You would actually do what you are comfortable with and what your unit is comfortable with. So looking at this video, this is a video of one of my cases in the cecum. As you can see, this is what looks like a serrated lesion. I call it a serrated because there's a bit of a yellowish top at the top of the polyp. And here I'm illustrating how you do an EMR. What is important is you go completely surrounding the polyp. You also ensure that you're not taking too much of a normal tissue. I think it's reasonable to remove a certain degree of 1 or 2 centimeters, 1 or 2 few millimeters of normal tissue. The more tissue that you try and remove it en bloc, you're increasing the risk of perforation. And your question would be: would you close this resection margin after you've removed this polyp? Again, there are no specific randomized trials, but in my theory would be, if you think that there's a high likelihood of a delayed bleeding, perhaps someone takes warfarin or anticoagulation, I would usually put clips. What is my strategy for a flat lesion? So flat lesions, which is what's called as lateral spreading tumors or lesions, you would classify it as 2 different types. One is lateral spreading tumor or lesion, which is of granular type. As you can see, this is the granular type. And this is the non-granular type where you see no granulation at all. So if you have a lateral spreading granular type, then you have a dominant lesion. So as you can see here with the red circle, you'd want to remove this an en bloc resection. As we saw from the ESG guidance, it's often difficult to do an en bloc resection of a polyp more than 2 centimeters. So you'd like to do an en bloc resection of this dominant lesion and perhaps remove the smaller bits, which is the non-dominant lesion, as a piecemeal resection. Whereas if you have a non-granular lesion, you'd like to do it as an en bloc, because then you would be able to provide the histopathologist a full sample and they can determine if there is submucosal invasion or not. And that's easier for the pathologist. So why are flat lesions important here? And I think I'm putting in another Scandinavian here, who's my guru from Leeds, who migrated from Sweden to work in Yorkshire. So his study goes back to almost 20 years ago, where he looked at the flat lesions and predicted the likelihood that this flat lesion may have early cancers. As you can see, the bigger the flat lesions are, they're more likely that these may have cancer. So these flat lesions are very, very important, and we need to remove them very, very accurately and efficiently. So here I'm just showing you a very quick 1-minute ER of a sort of a sessile lesion, where you assess the polyp, you do the narrow band imaging, which is very important, and you know whether it is an early cancer or benign, and then you would inject the polyp, and the reason for the injection is you move the polyp out of the mucosa lining so that you can delineate the different layers, and then you would start doing the piecemeal EMR. The way I would approach this is to remove the dominant lesion first using an en bloc resection, and then continuing to do piecemeal EMR. Here, as you can see, what I'm doing is to tidying up the edges of the polyp. The EMR is not complete until you have visualized the edges and make sure that the edges are treated. There are various ways that way you can treat the edges, particularly when you're doing a wide field piecemeal EMR. That can be done by either doing an avulsion technique, as I showed you in my own video and on the video on the top left, or you can do it by...
So that you have some additional protection.
Sorry. Or you could do a snare tip coagulation, or you could do argon plasma coagulation. There are several different types of treatment of the edges that you would do. I must admit, I do not see that there's any specific randomized controlled trials comparing the various techniques. However, I think you should do which way you're very comfortable with. When I first trained in Leeds with Bjorn Aabakken, we used to do a lot of APCs of the edges. However, they are going slightly out of favor, and we have resorted to doing very simple avulsion technique and also using soft tip coagulation more recently. The underwater polypectomy has become quite popular recently. The advantage of this is you do not use any submucosal lift, so you could argue saying that there's a cost issue as well as the timing that one takes in removing the polyp. Often, as you do, is using water to insufflate the colon is becoming very popular because that does help with patient tolerance. It also is supposed to reduce the time that the procedure takes. It can look quite elegant because, you know, as you can see from the video, as elegant it looks. However, there is no multi-center randomized trials currently done, and I'm not someone who does this routinely. So you'd be very interested to know how your difficult polyp would be. Your difficult polyp is something which is more than 4 centimeters, something that involves the IC valve, something that involves the appendix, something that is around the diverticulum or over a dentate line, or if there is an inflamed segment in Crohn's or colitis when there is an adenomatous polyp you want to remove, or if a polyp has been previously attempted to remove, then they do become difficult. It is also very important to assess your polyp to ensure that it's not a cancer already, as seen here, where you may have a pattern 5 on the on your chromoendoscopy, or if it's a depressed lesion, or if it has got a non-granular pattern, or if it has a very, very big nodule, or if it does have, based on the NICE type 3 classification. So I think whilst EMR is something very useful and very easy and very good technique, it's also important that, you know, you could still do cold snare, because cold snare is something that can be done without the need for diathermy. It's very effective, and it's as good as hot snare for up to 9 millimeter polyps. And more recently, there has been some studies which have looked at a bit bigger polyps that do more than 1 centimeter, and you can use some mucosal lift with this as well. So there are occasions when you would determine the polyp is not a polyp that you want to remove at this time, or you think that the polyp is actually cancerous already. Then you would put a tattoo. It is very important to tattoo. Then you can find where the polyp was. Is very useful for the surgeon when they want to go and look at the polyp operating at the time of laparotomy, or when they want to come again, or when you want to look at the polyp in the future for surveillance. It's very important to know exactly where you would tattoo. The guidelines that we use is the revised St. Mark's colonoscopy tattooing. There is a ESG tattooing guidelines which we all follow, which suggests that the polyp should be tattooed, or any lesion that needs tattooing should be tattooed distally. So this is towards the anus rather than proximal to the lesion. I usually tattoo by initially creating a bleb, as you can see here, with normal saline or just water, and then I use the tattoo or the ink to color it. I usually place, if it is a cancerous lesion, I place about 3 tattoos. It's very important not to put too much of a tattoo, because I think the worry is sometimes when you go and do a procedure, all you see is a lot of tattoo and the whole colon looks entirely black and you can't see the lesion at all. I'm aware that the ESGE is looking at a tattooing guidelines, which probably has been a bit delayed because of the current COVID situation. So I'm not going to talk a lot about endoscopic mucosal dissection. It's not something I routinely do. However, I think it's important that you think about this. It does give you an option of doing an en bloc resection. It can be curative if the polyp or a cancer is an early cancer with a submucosal invasion, just having an SM1, which is basically involving the upper part of the submucosa. However, as any technique which is very new, can be associated with a very steep learning curve, and it might take a long time for you to be skilled in learning. It does increase the procedure time. The procedure time can be very long, but that procedure time can be brought down with doing more procedures and getting skilled with it. It does have a high complication rate. In terms of the lower GI pathologies, the ESG suggests that if it is more than 2 centimeter, and if it is a non-granular LSD, or if it's a depressed lesion, you would consider doing an ESD. So as a final slide, just to pitch my own study, I'd like to invite you to participate in the polyp assessment at colonoscopy and inter-observer study, which is a registered study in Sheffield, and everyone is welcome to participate. There's a link that's available. I welcome you to participate. I can also send you the link by sending me an email if you wish. So in summary, it's important that every polyp is assessed by using the Paris classification. It's also very important to do an SMSA assessment, which is size, morphology, site, and axis assessment. And then you make a decision if you remove the polyp or you refer for surgery based on your assessment if you think it's a cancerous polyp, or do a resection if you think that you can remove that with your expertise and the time available. Professor Serag, thank you very much for your kind invitation. Shukran. And thank you.
Shukran, Mohamed Ramadan Kareem.
Thank you.
Thank you very much, Mo, for this presentation. And if anyone wants to add and ask any question, please go ahead.
Yes, I want to comment and ask a question. I want to thank really Dr. Lars and Dr. Mo for this really interesting and exciting lecture. You've you know, there are some of the flat polyps which really made us sometimes we miss during our normal colonoscopy. Do you have a special technique where you can really observe these very flat ones, which may be cancerous, and we are missing? And my other question is, you made us sort of that tattoo might be, you know, sort of a complication rather than a guide for the surgeon. When do what sort of limitation do we have to go on with the tattooing?
Excellent. Thank you very much. That's excellent questions. So the first question was about the flat polyps. I think you're very, very right that flat polyps can be missed very easily. Going back to my own story, my endoscopy guru is Aabakken, and he did his training in Japan. And when he finished his training in specific endoscopy and went to Europe, went to England, he talked about the flat polyps, and people said actually that flat polyps is a Japanese thing. This thing does not exist in the European population. But with time, we actually found that these polyps can be seen in everyone. And this is based on, as you quite rightly said, is very careful examination. The careful examination is done based on careful withdrawal. You withdraw very slowly. We also know that by getting the scope out very slowly, which is basically called, as you know, withdrawal time from the cecum to the rectum, you would use at least 6 minutes to 8 minutes, as we say. We know that the longer that you take, you actually see more flat lesions. You would also use certain position changes. We know that examining the transverse colon in a supine position does increase the yield of flat polyps, and likewise examining the right colon in the left lateral position increases the diagnostic yield of flat polyps. You also would like to use Buscopan because Buscopan will relax the colon and that can examine. On some occasions, you may want to use dye spray colonoscopy, particularly if it is a high-risk patient with polyposis. We don't routinely dye spray the colon in all our diagnostic colonoscopies, but we do use them in polyposis syndrome. That's the way that I would do to increase the yield of flat polyps. The second question about tattoo is a very good question. I think more and more people are shying away from polyps. So as in they're seeing a polyp, they're taking a picture, and they're leaving it for experts to remove. And invariably they're putting tattoos. The difficulty is there's only one colon, and people do have a lot of polyps in lifetime. So the more you tattoo, and then they come back for another polyp, and then you tattoo them again. So I would follow the European Society of Gastrointestinal Endoscopy, the ESG guidance, which clearly says that you would only tattoo lesions or polyps which is not in the cecum or the rectum. So because they are very easy to identify, the cecum or the rectum, you spare them. And you would tattoo distal to the polyp, and you would only tattoo as limited as possible. You don't want to tattoo too much, which usually, if it is a benign polyp, which you want to just bring them back for an expert to remove, I'll just tattoo one area. However, if it is a surgical case where you found a cancer and you want to refer the case to a surgeon for laparoscopic removal, then you would tattoo in 3 locations, which is usually will be distal to the cancer. But the ESG also clearly says that you should follow the local, which is what is agreed in your local hospital, because you don't want to disappoint the surgeons.
Presentation as usual, Mo. We missed you meeting as usual in March, but we will do it inshallah. Important, the comment here is about small polyps. So whenever you find a small polyp, just remove it. Don't wait until you go on your way back, because usually you will miss. This is number one. Number two, in cases of large polyps like you show us, when you go for a second look to check for residue, because you may miss some lesions. So when you will go for a second look, and for the intervals for rechecking, you go for 3 years, 5 years, 10 years for follow-up colonoscopy.
Excellent question. So I think I unfortunately missed the Egyptian trip because of Corona, But inshallah, we'll make it when Corona gives us a clearance. So I think the first question was about, or comment I think you mentioned about small polyp. It's very, very important, and when you're inserting the scope, that you remove small polyps. I say small polyps because then you have to determine what you define by small polyps. I mean, for me, anything which I can remove using a cold biopsy forceps, which is usually about 4 to 5 millimeter or less than 5 millimeter, I will remove them using a cold biopsy forceps on the way in. And anything beyond that, and you think you might miss the area, I could even take a tiny biopsy of that area, not biopsying the polyp itself, but just biopsy surrounding it. So it gives you a little mark when you come out, because you don't want to put a tattoo for that small polyp. As we said, we're trying to avoid tattoo completely unless it's really needed. So that will be my way of dealing with small polyps. Sorry, I missed the second one. Was it about tattooing?
The second look for large polyps.
Oh, yes. Excellent. The second look for the large polyp, again, there is a more recent British guidelines which came up. It was published by Max Rutter quite recently. And the advice is, of course, if it is based on the fact that have you done a proper full colonoscopy, because what you don't want to do is you don't want to have done a good colonoscopy and done the EMR or polypectomy, but you're not sure about the bowel prep. You may have not seen a flat cancer. So if the bowel prep is poor in your index colonoscopy, you would actually repeat the colonoscopy based on the fact that the prep was poor. That should be based on your own local guidelines. I mean, if I think the prep is not very good, I usually bring them early rather than late. That could be between 3 months to a year. That's based on the fact that the prep wasn't very good. In terms of if I've done a wide field EMR, I tend to bring them within 3 to 6 months for a second look. And that's, as you quite rightly said, to look at the polyp, and because that's the best time to deal with any residue.
One question?
Mohamed, before you ask, we need short questions, short answers. Otherwise, you will not go home.
Just one question.
The problem is that you are at home.
Okay,
Very relaxed.
that's one question. Thank you very much for this great presentation. You showed us piece of art, the way you are removing the polyps. My question is, I'm a big advocate of ASDs in the colon, of course, with the right indication to avoid this RX situation. Yeah. Do you agree with this? If we have the right indication to go for ASD, or you are a big advocate of piecemeal MR? If not, how often do you face this RX problem and you have to send the patient for surgery?
I think excellent question, comments. Great to see my good friend from Germany, as always. Yes, I'm not anti-ESD at all. I think ESD should be done wherever the expertise is there, particularly if you have a flat polyp LSD, which is non-granular or depressed, or which has got a very significant dominant lesion. Yes, it should, if the expertise is there, and if you have a time and a good expert pathologist to look at it, yes.
And how often do you see this RX problem?
In terms of the, if it is in a benign lesion, the recurrence is, I think, variable. I think with expert and good hands, with very good technique and ensuring that the edges are well cleaned, it could be less than 10%.
Okay, but just a small question. The polyp you tattooed, it didn't look very tumorous out. Was it really a cancer after surgery, or this pedunculated nice polyp you tattooed?
No, it was a benign one.
It was benign. Okay.
Yeah.
Okay. Thank you very much.
Pleasure.
Ahmed, before you leave, some asking me about your beautiful slides and the polyps and the mucosa. How do you clean your colon? Preparation you use?
In Germany or in England?
You, Mohamed.
Oh,
Yes, I think in England for screening colonoscopies, we usually do what's called as an augmented bowel prep, which basically means that patients are advised longer low residue diet. In standard ESG, it says only 1 day low residue diet. However, we do for screening advise longer than that, which is about 5 days of low residue diet. And we give them a pegylated type of bowel cleansing, which is usually a clean prep or movie prep based on what is available locally. But it is very, very, very important, I stress this, to consider split dosing and not give them all in one. Even if the patient is coming for a procedure at 9 o'clock in the morning, consider split dosing, which means they have to wake up at 4 in the morning. But my argument is, if they have a flight to catch, say, for example, from Cairo to Germany, and they have a morning flight, I'm sure they will wake up at 4 in the morning. So I think it's reasonable that.
Thank you. Very short answer. If you have time later, you have another question about limitation of EMR. When you stop and when you don't attend. Now, Dr. Shariha introduce Abdelhafez. Yeah.
Shariha.
You are mute. Yeah. Yes, you can.
Serag. Salem Awad.
Yes.
No, listen.
still muted. Still muted.
Muted.
Serag. Stars. I have one comment.
Yes.
You couldn't.
Comment.
It's a pleasure to introduce Dr. Mohamed Abdelhafez. He is a gastroenterologist and endoscopist from Munich, and he is in Recht Ishar Hospital, if I pronounce it properly. Yes, and welcome to this session.
Thank you very much.
You will talk on EUS-Guided Gastroenterostomy.
Exactly, yes.
Can
you see my screen?
Yeah.
Okay. I'll just start now. Just before I start, I would just comment on Dr. Serag's question about the preparation for the colon. Here in Germany, I did like 100 Egyptian patients, and they do the same preparation the Germans are doing, and the colon is never clean. So maybe it's something to do with the nationality, I don't know. But maybe
diet.
Through a study or something to check if the Egyptians need more preparation than the normal population. Okay, I will start now my presentation. Thank you very much, Dr.
Diet and long colon.
Invitation. I will talk today about EUS-Guided Endoscopic Gastroenterostomy. It is the cutting-edge technique in the endoscopy. Actually, it is the most recent technique in the world of endoscopy. Very interesting technique. It's nice and simple. I will not go in many details or literature today. I will just talk more about the indications and the technique. I will talk about two entities when to do this EUS-Guided Gastroenterostomy. One entity will be the gastric outlet obstruction, and the other entity called afferent loop syndrome. I will explain later what is it. So, the management of gastric outlet obstruction. We have a patient with gastric outlet obstruction, let's say because of tumor, because of any kind of obstruction, pancreatitis, any reason. How to manage these patients? One of the options is to do a bypass procedure, a gastroenterostomy, an anastomosis between stomach and small bowel. Surgical bypass can be laparotomy or laparoscopic. Other option is stenting, to put a stent through the stricture. It can be covered metal stent or uncovered metal stent. You can do also double stenting, like do ERCP first, not to obstruct the bile duct, and then do a duodenal stent. Another option, especially for the patients with malignant strictures, is to do a PEG, to put a PEG to extract the secretions of the stomach outside, or to put a nasogastric tube also to extract the secretions, which from the point of quality of life is not that good, especially if we expect the patients to live for a couple of weeks or a couple of months. Balloon dilatation, of course, will not be convenient in malignant strictures. And the new techniques is the endoscopic bypass. There were multiple trials to do nodes with these patients. There is no evidence that it works. There is magnetic compression to put a magnet in the stomach, a magnet in the small bowel, and with time they will create a fistula or anastomosis between the stomach and small bowel. Also, there is no good evidence that this method works. And our method today, our technique today, the EUS-guided gastroenterostomy. So just very quickly through the literature, a comparison between surgical gastroenterostomy versus putting a stent through the stricture in the duodenum, for example. In this study from Amsterdam group, they showed that the stent, patient who got the stent had less hospital stay than surgery, which is logical. They can start solid food intake earlier than the surgical patients, but the recurrence rate was much significantly higher with the stent group. And that can be because if you put an uncovered metal stent, it will be occluded with overgrowth. If you put a covered stent, it can dislocate very quickly. The gastric outlet obstruction score above 2 was had longer time with surgical patients than the stent group. So they can tolerate more food in surgical group than the stent group. So from this study, we can conclude that if the life expectancy for the patient is longer than 2 months because of the recurrence rate, it is better to do surgery or to do a bypass procedure. If the life expectancy is less than 2 months, it's better to put a stent. It will be occluded anyway, but the patient might die before that. Now, surgical gastroenterostomy versus endoscopic or endosonographic guided gastroenterostomy. In this retrospective analysis with 93 patients, the success rate was significantly higher in surgical group, but the clinical success rate was comparable between the two groups. The recurrence was higher with the surgical group, but not significant. Complications rate were higher with surgery than endosonographic guided group. But to conclude this study, they are comparable to each other with more complications with surgery. If we will compare EUS-guided gastroenterostomy versus stenting, we can see here also to conclude the need to do reintervention is significantly higher with the stenting in comparison to EUS-guided gastroenterostomy. As I said, the overgrowth will occlude the stent if it is uncovered, or the stent will dislocate or migrate if they are covered. So the EUS-guided gastroenterostomy technique, the development of hot axio stent, which was done with this brilliant guy, the Ben Müller, made this technique possible. Actually, they started like 20 years ago to do some trials to do gastroenterostomy with the group of Suhendra in Hamburg, which failed massively. They tried over and over till Ben Müller invented this hot axio stents. And the stent looks like this. It has a metal tip, which you can put electricity through it to puncture through the stomach. You can put a wire, then you can deploy the stent. This is the inner part of the stent, and this is the complete shape of the stent. It's called lumen opposing stent. It is covered. It has this dumbbell shape, so you don't have risk of leakage if you put it between two lumens. In this video, you can find this video in YouTube everywhere. It is how it looks like. It has this application system. It looks a little bit complicated, but it is not. If you have enough training, you can learn it very quickly. There are 4 steps. They are numbered here from 1 to 4. This is how it looks when you deploy it. And there's a very nice video clip here. Yes. So you puncture the stomach like this. You enter the other lumen, small bowel, with electricity, of course. Then you unlock and you go for step 2, which means the deployment of the inner part of the stent. You remove this yellow part and you withdraw it backwards. Here we can see here the endosonographic image. This is the inner part. Then you withdraw the stent backwards with the step number 3. and then you will deploy the external part. Here we can see in the endoscopic image when it is deployed. The first use of this stents we used previously to drain pseudocysts after acute pancreatitis or to do necrosectomy, and then Ben Müller developed this gastroenterostomy technique. There are different techniques how you do the anastomosis with this stent between the stomach and the small bowel, the gastroenterostomy. One method called direct puncture, it is quite dangerous because you puncture directly with the stent in a collapsed small bowel, which I wouldn't advise. And then they developed this method called inflated balloon catheter. They put balloon catheter, like the stone extraction balloon from ERCP, they put it deep in the small bowel, they inflate it with water, and they will use this balloon as a landmark. So they can see it with the ultrasound and they can puncture it. They use it as a target to puncture from the stomach and the small bowel. It is a little bit complicated. And this is small bowel distension with diffuse water filling technique. This is the method, the most common method that is used, that I use personally. You just put a catheter in the small bowel, you inflate the small bowel with water, and then you can see the small bowel from the stomach, and then you can puncture it. This device called EPAS, which was invited by a Japanese colleague, it has two balloons which will block a loop from the small bowel, and between these two balloons you can fill this segment with water so it will stay fixed and stable. Then you can puncture it from the stomach. And you can use two endoscopes. This is also described, this technique. I don't like it. I used it once. It is very complicated. It is a lot of work and it is not very convenient. So this method, filling the small bowel with water through a nasobiliary catheter, is the best way. That's how we do it. First of all, we have to access the jejunum, which means you take a small caliber endoscope, try to pass a wire through the stricture deep in the small bowel. Over this wire, you will push a nasobiliary catheter. Through this catheter, you can bump or fill the small bowel with water. You can mix it with blue color. And it should look something like this. This is, here is the catheter in the small bowel, and this is the EUS endoscope. After filling the small bowel with water, like here, we can see here the catheter. This is the small bowel. Can you see my pointer or? Okay. In the second picture here, we can see we puncture from the stomach in the small bowel with this needle. Why we do this? To inject contrast metal and to aspirate. And when we aspirate the fluid, we have to see this blue color we injected with the water, just to make sure that we are in the right small bowel loop and not in the colon or not in the gallbladder or not in any other organ. Once we confirm this, we withdraw the needle and we do our puncture. And this video will show an example. Now we punctured the small bowel with the hot axius. And we deployed the inner part of the stent, the inner tulpa here. And we withdraw it very slowly backwards till we have some tension. Now we shift to the endoscopic picture. Now we are in the stomach and the external part of the stent will be deployed. We do it very slowly. Actually, it takes like 2 minutes to finish this procedure with the hot axius stent. Now it is deployed. And now we have the anastomosis. What you will see now, that I will do balloon dilatation of this stent. Actually, I don't do it anymore because there is some case report that the stent was dislocated with balloon dilatation. You can just leave the stent and it will be completely dilated within 24 hours. And you can see here the small bowel very clearly. You can go through it with your endoscope. Also, I don't advise this anymore because still also there are some case reports that the stent can dislocate during this. And it is finished. The patient can start taking fluid afterwards at the same day, and most of our patients can go home after 2 days. The complications that can happen during this is peritonitis, bleeding, misdeployment of the stent. Of course, the stent can be misdeployed in the peritoneum or in the colon, something called gastrocolostomy, like instead of gastroenterostomy, you have the anastomosis between the colon and the stomach, which is very bad complication, or a perforation. Now I will discuss very quickly this afferent loop syndrome. What is afferent loop syndrome? It results from mechanical obstruction of afferent jejunal loop following construction of gastrojejunostomy. The patients with gastrojejunostomy, as we see here in this picture, they have afferent loop and efferent loop. The afferent loop has the biliodigestive anastomosis, the anastomosis between the jejunum and the liver to drain the bile. If this afferent loop got obstructed because of any reason, because of inflammation, tumor recurrence, or anything, this loop will be distended. It will build up pressure with time, and it will end up that the pressure will go here high and cause cholestasis. And till now, the standard management of these patients were surgery or percutaneous drainage. This patient was referred to us with afferent loop syndrome, and they drained it because they couldn't reach the biliodigestive anastomosis to do ERCP. They drained it with percutaneous drainage. We can see here the percutaneous, the PTD drainage, and we injected here some contrast metal. We can see the biliary tree, and here is the biliodigestive anastomosis. And I had this idea to connect the afferent loop proximal to the obstruction, to the distal to obstruction, so it will have a bypass. And that's what we have done. We injected a lot of contrast metal. As we can see here, this black big area is all afferent loop, obstructed afferent loop, full of bile and secretions. So we filled the loop, and from the proximal part of the jejunum, we did endosonography. As we can see here, when we inject the fluid through the percutaneous drainage, we can see this turbulence here in the fluid, which means this is the right loop that we have to bypass. And with the endosonography, we inserted the needle first to make sure that this is the right loop. And then, as we can see here, and then we deployed the hot axial stent between this afferent loop and the open loop, just to bypass this obstruction. This is the inner part of the stent. It will be withdrawn a little bit. And this is here in this fluoroscopic picture, we can see here the deployed axial stent is completely opened, balloon dilatation, and we can see the contrast metal went very smoothly from this closed or obstructed loop to the open loop and to the stomach. This is the endoscopic picture. We can see here from the open jejunal loop, this is the hot axius. And in this video, we will enter through this hot axius stent in the afferent loop. And this white stent is the percutaneous drainage, which comes from the biliodigestive anastomosis. The patient went fine. We could remove the percutaneous drainage after a few days just to make sure that everything is fine. And she lived her life without any complications. Conclusion, EUS-guided gastroenterostomy is as good as surgery with less complications, with early, they can start eating earlier than surgery. They have less complications than surgery. EUS is ideal for malignant gastric outlet obstruction. It is better than stenting if we took into consideration that the patients will live longer than 2 months. Of course, further technical modifications and developments are warranted for more safety and easiness. The most recent thing in this technique, they have released now the 2 centimeter diameter hot axial stent, which is big enough that the patients can tolerate solid food after the procedure. Thank you very much.
Thank you, Mohamed, for this very nice session as usual. very advanced and very up to date. And any comment from our colleagues,
Yes.
Salem, Ziad, Ahmed, and others?
Yes.
Salem.
Dr. Naam, Mark. Thank you, Dr. Mohamed, for this lecture on advanced endoscopy. I just want to add that there are 3 US-guided gastroenterostomy, the direct one, the assisted technique, and a variant called the EUS-Guided double balloon. And recently, we have a patient who had a duodenal tumor, which was removed by endoscopy, and he developed bleeding, and then the surgeons did Whipple's surgery. And after Whipple surgery, he developed obstruction in the duodenum. And the discussion here is either to put a stent, which may be hazardous, or to do the procedure of EUS-guided gastroenterostomy. What is your opinion in such a case? Is a young man, the tumor is high-grade dysplasia, early malignancy, and it was totally removed endoscopically.
Very nice question. It always depends on the anatomy of the pictures. We have to revise always before we do go for this procedure. We have to revise the CTs. We do also barium meal to see the complete anatomy and to see if there is a good loops that we can do the bypass between them or not. This is very important to find a good window to put your stent. If it is doable, then I will go for gastroenterostomy. The only thing I couldn't understand from this, if he received Whipple, then they should have removed the duodenum as well, or not?
They removed the duodenum, and but
the gastrojejunostomy now.
Yes.
I will manage it exactly as this afferent loop syndrome. I will try to identify where exactly is the stricture. Is it in the afferent or the efferent loop? And then I will try in the CT and the barium meal to see if we have a window between the stomach and the small bowel to bypass this stricture. Is it possible or not? If it is, if we have a good window means a short distance, shorter than 2 to 3 centimeters, that we can deploy the stent. Then of course I will go for gastroenterostomy, because if you will put a stent, put a duodenal stent, which stent that you will choose? Is it uncovered? Again, if you will put uncovered the stent, you will not be able to remove it again if any complications happen. If you will put a covered stent, you have a very, very high probability that the stent will dislocate.
Very great.
Yes.
Thank you.
Ahmed, what about this procedure time? How long, in average?
You have 2 parts during this procedure. The first part, you will go with the normal endoscope to put the nasobiliary catheter. That can take like 10 minutes or 15 minutes. It depends how tight is the stricture, how difficult. Once you change to EUS endoscope and you identify the loop, it will take something between 5 to 8 minutes or something.
So 1 hour?
Overall, no, it never happened that we took 1 hour to put gastroenterostomy. Maximum, it will be something between 25 to 30 minutes.
Of course, if compared to surgery, it's marvelous.
Under GA and intubated because it's a gastric outlet obstruction. So chance of aspiration is high.
I only did 1 patient under anesthesia because of other reasons, because it was difficult to sedate with propofol. In Germany, we give propofol ourselves. We keep patients with nasogastric tube 2 days before the procedure just to empty the stomach. We try to be very cautious. We start our endoscope with a big caliber working channel to aspirate or to suck any secretions in the stomach, and then we continue with the procedure. So I did it only once. I did till now something between 38 to 40 cases. Only 1 case I did with general anesthesia, with intubation, and we didn't face any bad aspiration during the procedure.
Question coming from Abdelhafez: how to manage complications of gastroscopy? When we need surgical
Very nice
interference.
Very nice question.
Mohamed,
Yes.
when you need surgical help.
Very good question. First of all, you have to identify the complications as soon as possible. I was lucky till now that I didn't have mortalities, but I witnessed, because also it's a new technique. There are some colleagues they are doing, they want to do it. So I remember one colleague called me. He tried to put the axius, and then the axius was dislocated in the peritoneum. Okay, so one part of the axius was in the peritoneum, and the other part was in the small bowel. And there is a small opening in the stomach. I had to go to him at 10 o'clock in different hospital, and we did something like notes. I entered the peritoneum with the normal endoscope, and then I made an extension with a big metal stent between the stomach and the small bowel. But as I said, the most important thing to identify the complications as soon as possible. If the technique is successful, you will have to give contrast metal. We give contrast metal afterwards to see that everything, there is no leakage. This is number one. It is pain-free procedure. If the patient has any pain after the procedure, you have to be worried. If you have peritonitis, signs of peritonitis or abdominal inflammation, any complications, fever, anything, you have to go to do CT to discuss the case with the surgeon as soon as possible, because it can be fatal. And all these cases should be discussed in tumor board and with your surgeon before you do it, to have a full backup before it. And the patient should be consented that this is a new technique, is still under investigation, because there is enough literature till now, but there is still no big evidence to support it. The patient should be consented for this.
Shukran, Mohamed. Any other question to Abdelhafez? Okay, thank you. We move now to Salem for the next speaker.
Thank you. It's a great pleasure to welcome Dr. Mohamed Abeid, a gastroenterologist from Cairo, who will talk on endoscopic treatment of morbid obesity. Welcome, Dr. Mohamed.
Good evening. I would like to thank Professor Serag. I would like to thank you all. My topic is on endoscopic management of obesity and metabolic diseases.
صوت يا محمد. Your mic is not adjusted.
كده أحسن يا فندم؟
أيوة كده أحسن.
I have nothing to disclose. I'm going to speak about the introduction. Endoscopic management is divided into gastric and small bowel. Then conclusion. Nowadays, endoscopic procedures are more effective than lifestyle and medication, and are less risky and less side effects than the surgical procedure. Endoscopic bariatric and metabolic therapies are divided into gastric, mostly restrictive, and small bowel, mostly malabsorptive. The American Society of GI Endoscopy and the American Society of Metabolic and Pediatric Surgery said they should have an incidence of side effects less than or equal 5%, and they should result in more than or equal 25% excess weight loss at 12 months. And both societies set a threshold for any EBMTs and indication to be as follows: as a primary therapy of obesity, to treat metabolic diseases, as a bridge to surgical therapy, or to manage weight regain after bariatric surgery, or to manage complication of bariatric surgery. I'm gonna speak about the first two indications. Obesity is a global epidemic, and at the global level, the future is bright for the endoscopist.
Wow.
The first intervention is a gastric intervention. I'm gonna speak about the intragastric balloons. They have been in the market since 1985 by the Garen Edward balloon. Since that time, many companies developed a lot of balloons. They differ in their manufacture, in their filling volume, and methods of introduction to the stomach, the method of removal. The last two balloons, they don't require endoscopy either during insertion or removal. We have now adjustable balloons for 1 year. This is a study done in Egypt by me and my colleagues on 1,600 cases. We inserted Orbera balloon. We have more than about 50% of our patients lost 10 to 20% of their weight. We have significant decrease in HbA1c and blood pressure during 6 months. We have less than 5% side effects with zero mortality. This is the Brazilian guidelines done on 40,000 patients. They insert a different balloon by 37 endoscopists. They have total percent weight loss of 18.4%, which is quite very high. Their side effects were less than 5%. And they have guidelines on the use of PPI throughout the 6 months or 1 year, depend on the balloon used. And non-steroidals are not recommended as long as the balloon is inside the stomach. This is a very nice article published in the official journal of the American Society of Metabolic and Bariatric Surgery. For those morbid obese patients refusing surgery, they can benefit from multiple balloon placement. This is a follow-up study for 6 years. It stated that multiple intragastric balloon is recommended treatment, allowing patients to achieve a good weight loss, better control of comorbidities, and better quality of life than at baseline. This study is published last week online by Barham Aboudia from Mayo Clinic on the effect of intragastric balloon on NASH, and 50% of the patients reached endpoints by the FDA for NASH resolution and fibrosis improvement. This is an FDA update last week about the risk of hyperinflation that occurred with 2 balloons used in the US, Orbera balloon and the reshaped balloon. The reshaped balloon is no longer in the market. About the Orbera balloon, this is 258 post-approval study. They have 0 deaths, 0 acute pancreatitis, 2.3% hyperinflation. And this is important for the gastroenterologist to know about this complication. In any patient have prolonged symptoms after 1 or 2 weeks after balloon insertion, the patient should be evaluated for the risk of hyperinflation and should have his balloon removed. The second device I'm going to speak about is the endoscopic sleeve. It is similar but not identical to sleeve gastrectomy. It reduces the entire stomach along the greater curvature, creating a sleeve, a full thickness suture through the gastric wall extending from the antrum to the gastroesophageal junction using FDA-approved suturing device, and it required a gastroscope aided by a tissue helix. This is a device, and this device now can be used with any single channel scope. And this is a picture of the stomach before. This is a picture immediately after, and this is 3 months after. Here is a small video illustrating how we do the sleeve, endoscopic sleeve. First, we use argon to mark the anterior and posterior wall of the stomach. Then we start suturing the stomach to induce the sleeve. First, we take an anterior wall, greater curvature, posterior wall. Then again, anterior wall, greater curvature, posterior wall. Then we place an anchor and then we cinch. We do this in the stomach 4 to 5 times to create the sleeve. This is the largest multi-center retrospective study, including 248 patients, done by Lopez Nava in Spain. He has 18.6% total weight loss at 2 years, with 2% side effects, including perigastric fluid collection, extraluminal bleeding, pulmonary embolism, pneumoperitoneum, and pneumothorax, and no mortality. This is one of the largest single-center study done by Abeid Kahtani from Saudi Arabia. He done endoscopic sleeve on 1,000 patients. He have 64.7% excess weight loss at 18 months, which is very close to sleeve gastrectomy. Side effects were less than 5. The most important thing in this study is that he has complete resolution of hypertension in 28 patients, dyslipidemia in 18 patients, type 2 diabetes in 13 patients. This is another study done by Shariha from New York. She had head-to-head trial in comparing endoscopic sleeve by laparoscopic sleeve and the laparoscopic band ligation. The endoscopic sleeve, the patient lost 17.5% total weight loss, although they are lesser than the laparoscopic sleeve, but the endoscopic sleeve, the patient lost more than those who did a laparoscopic gastric band. As regards side effect, the endoscopic sleeve, we have 1% side effect as compared to 10% in the laparoscopic group or 11% in the lap band group. The last study on endoscopic sleeve, this is published in the April journal of GIG journal last April. They compared endoscopic sleeve with laparoscopic sleeve. The new onset GERD, which is very common with the laparoscopic sleeve, was only 1.9% in the endoscopic group. The third device for the gastric remodeling is the primary obesity surgery endoluminal or POWS. Here, we use 8 transmural tissue anchor plication that reduce accumulation in the fundus. And we place another 3 plication in the distal body, performed using a large over tube platform that accommodate the slim scope and 3 specialized instruments: endoscopic grasper, tissue grasper, and tissue anchor delivery catheter. Here is the device. This is the POWS device. and this is the accessories we use. And this picture comparing
صوت يا Mohamed, your voice.
This picture comparing pose with endoscopic sleeve. Here pose, we do the suture in the fundus and distal body. The endoscopic sleeve, we do the suture along the greater curvature. And this is a small video demonstrating how we do the pose procedure. We first grasp the tissue, then we place 2 anchors on each side, then we cinch. And this is the picture, as I said, we do 8 sutures in the fundus, 4 in the distal body. This is a study done in Egypt by me and Professor Carl Mera, the ex-president of EUS. We have 6 patients. Excess weight loss was 44%. Side effects were vomiting, nausea, pain, and sore throat. This is a large systemic review done by Grace Thompson from Harvard, from Boston. Meta-analysis including 586 patients. They lost 13.2% at 12 months. The adverse event was 3.2, including extraluminal bleeding, minor bleeding at suture site, hepatic abscesses, chest pain, nausea, vomiting, abdominal pain, and again, no mortality. This is another pose called pose 2 device. This includes suturing in the body of the stomach and not the fundus and the antrum. We spare the fundus and the antrum, and we do the suture in the body. Focusing on the body lead to greater effect on motility and greater effect on weight loss. Here, the patient lost 56% excess weight loss, which is quite very good. The 4th device in the stomach is called aspiration therapy. It required 1/3 of the meal is removed via a gastrostomy tube. Aspiration is performed by a siphon effect 20 minutes after the meals. It takes about 5 to 10 minutes, and here is the device. And here the patient can do the siphon effect by himself. And this device is FDA approved on June 14, 2016. This is a study done by Shelby Sylvian from Colorado. The patient lost 55% at 2 years. The last device in the stomach is called the transmydoid shuttle. It involves the placement of large spherical bulb and smaller bulb through an oval tube in the stomach where the device is self-deployed and self-assembled. The large bulb prevents migration into the duodenum, and it acts as intermittent seal to delay gastric emptying and induce early and prolonged satiety. Here, the video, you can see how we introduce the device, and this is the shape of the device. This is a trial done on 270 patients with 9.5% mean weight loss at 12 months and 30.9% excess weight loss at 12 months. And this device is FDA approved on April 16, 2019, last year. And here is the device. And you can see in the video, we do self-assemble the device, and then that's the device after the meal. It moves upward and downward with meal, but this bulb, large bulb, prevent migration to the duodenum. The small bowel, the proximal small bowel is efficient in nutrient absorption and play a major role in glucose homeostasis. Bypassing this proximal small bowel may contribute to weight loss and diabetes improvement. I'm gonna speak about 3 devices. The first one is the endo barrier of the endoscopic sleeve. It's a 65 centimeter impermeable sleeve of Teflon advanced within the delivery capsule. It's advanced proximal jejunum and then anchor crown deployed within the duodenum bulb, and it is removed endoscopically after 1 year. This is the shape of the device, and this is the anchor. And this the video will demonstrate how we introduce the device. Results of 7 studies reported excess weight loss 30 to 47%, and 3 randomized control trials showing HbA1c drop from 0.9 to 1.7. Complications are as follows: pain, nausea and vomiting, early removal, migration, pain requiring early removal, GI bleeding, the most important of which were liver abscesses that required the FDA to suspend the trial, but they have another trial ongoing now. Here's the delivery capsule, and then we will start to open the device. As you're gonna see here, we remove the capsule and then we open the device, and that's it. The second device is called DMR, or duodenal mucosa resurfacing procedure. It requires thermal ablation of the superficial duodenal mucosa using radio frequency. Mucosa remodeling may hypothetically reset the duodenal interior endocrine cells that have become diseased. Restoring signaling can improve diabetes control through an incretin effect. It is useful in managing type 2 diabetes in normal weight and obese individual. And here is the device. We first inject saline to to elevate the mucosa, and then we start radio frequency of the second part of the duodenum. The last device I'm going to speak about in the small bowel is the use of magnets for endoscopy. Now we can create incisionless magnetic compression anastomosis, such as gastrojejunostomies, gastroileostomies, and duodenoileostomies. After 1 week, this compression anastomosis is formed. A study done on 10 patients, they lost 14.6% total weight loss, and they had a decrease in HbA1c of 1.9% at 1 year. Here in the video, you can see the endoscopic view. This procedure required the use of endoscope, upper endoscope, or enteroscope, and a colonoscope. They insert the magnet first, then they do the coupling under X-ray. Here you see the two magnets are coupled together under X-ray. After this coupling, this is the laparoscopic view just to show the coupling. After that, they cut the suture of the magnet and they release the magnet. And this is a picture of the gastroanastomosis after 2 months. As you see, very nice and clean gastroanastomosis. Now, as you see, many devices are now in the market. Some have been approved in some European countries, some are still in development with very promising results. So at the end, wake up, obesity is a disease. Endoscopy may offer a solution. Endoscopy may cure diabetes. That was Jacques Devier 10 years ago. In conclusion, EBMTs hold the promise of providing the next major breakthrough in the management of obesity. The currently investigated devices have established promising outcome. They will not be effective without supportive lifestyle therapy. Further studies will help define their optimal role. Don't forget, they are not a magic solution. They are just a tool. Stay safe, everyone, and thank you.
Shukran.
Thank you, Dr. Mohamed. Very nice. Very heavy traffic. And a good meal in Ramadan. Any comments, please, from the audience or from you? I'm checking the audience regularly. I have altered the anatomy after resections and by bariatric surgery. I think not for you, this.
No.
Okay, Mohamed, thank you very much for this great presentation. Very informative as usual. Very great. Just one question, Mohamed. You mentioned like 10 or more than 10 procedures.
8 devices.
88.
8 in the stomach and 3 in the small bowel.
Okay, there are many. Why is the only popular device till now and the most successful one is the balloon? Why the others are just commercial or just not working or just not that popular? It has something with the difficulty to apply or the price or they are not working or why? Why it is only the balloon? It is the single procedure that is really working and popular.
Excellent question, Mohamed. The balloon is the cheapest, or first quote, according to the price, it's the cheapest for all. And it is easy to learn. It's a very short learning curve to insert. Anyone can insert a balloon. But suturing, it requires technical skills. Not anyone can do suturing. Suturing requires a learning curve, up to 55 cases or something. And balloon have been in the market since 1985, as I said. The other devices, the bows, have been in the market since 2008, I guess. So, and still, some are not approved. The balloon is approved like 2015. In Egypt and in Europe, the balloon is approved from I guess, 1995 or something. The other device is still recently approved. Okay. It just got approved like 1 year ago or 2 years ago.
And as an expert, how do you see the future of endoscopic management of obesity? It will be balloon or it will be one of these devices? How do you see?
Promising. The same that happened with the cardiology. You know, in the past they used to have an open heart surgery. Now you can insert a catheter from your arm or your leg. And
no, I mean, which device do you believe it will be the future for the? Is it the balloon further development, or it will be one of these devices you mentioned?
Endoscopic.
The balloon and the suturing devices.
Suturing.
The suturing device, they are very, very promising. Not only for obesity management, also for weight regain after bariatric surgery. You know, many patients they regain weight after they do bypass or they do sleeve gastrectomy. Now we can suture them again without the need for surgical interference. So it is very promising, very good outcome for using suturing devices on those who had weight regain after bariatric surgery. or in any case that have polypectomy and they have perforation, we can suture it. We can suture any stent to prevent migration. So it has a lot of uses. So the suturing device is very promising.
Is it true that the mucosa on mucosa, they will never held together for a long time?
I don't
It was a debate between me and the chef of the surgery here that mucosa on mucosa will never stay a long time.
I guess so, yeah.
Cirrhosis on cirrhosis, it will never work.
Yeah, I guess so, yeah. And that's why it's repeatable. Like if you go do a scope for this patient after 1 or 2 years, you will see everything is like decrease in size again, and you have to repeat it again. You have to do the suture many times.
Thank you, Mohamed. Thank you very much.
Morbid obesity management is a dilemma, like GERD.
Yeah.
A lot of opinions, a lot of trials, a lot of methodology. We have 2 presentations, small presentation, one from Professor Moataz Said from Ain Shams and another from Dr. Younan Kabara from Nasr Aini. Dr. Moataz, would you please, shukran ya Mohamed, would you please share your presentation?
Serag.
Okay, 1 minute.
So until Dr. Moataz load his presentation to Dr. Mohamed Abeid, thanks for the presentation. But combining the balloon with other modalities, the medical modalities like the use of GLP, the Saxenda, and all these stuff, do you think that this is worthy for weight control?
Yeah, sure. This is a very excellent question, and a lot of studies are now going in the US. They combine the balloon with a lot of medications, and they have very good results, better results, especially those who had less weight loss on the balloon. They can benefit from the add-on medication.
Yeah, thank you. Now, Dr. Moataz.
Good evening, everyone. Ramadan Kareem. I will give a short presentation about the rare cause of gain weight after bariatric surgery. It contains very nice video to demonstrate this case. First, I will give a short hint about the patient. This 45 years old female coming to our office 10 years after do vertical band gastroplasty. The patient is initial weight before the vertical band gastroplasty was 180 kilograms, body mass index 40 kilograms per meter. The patient lost 40 kilograms of excess weight within the 10 years, with total percent excess was loss is around 96%. All that time, she have complaining of recurrent vomiting, nausea. She cannot take any fibrous food. She take all the medical management, about double doses proton pump inhibitor, but she doesn't respond. But suddenly, last 2 months, when she come, she said that she can eat, vomiting stopped, she feel well, but she start to gain weight. In the 2 months, the weight increased 10 kilograms. First, we need to do the modified anatomy after this operation, which is not done now. It is done before 10 years and not used now because it is after many times she caused gain of weight. She needs restricted food restriction. The patient not take any fibrous food because it was vomiting and it caused severe heartburn. What is the vertical gastroplasty? What's the modified anatomy? To know in the operation, to know the complication which occur after that. This is short video here. As we see, first he divides the stomach by stapler to small pouch and large stomach. And the small pouch which contains the food is connected to the large pouch by a small fistula which is surrounded by fibrous band, which prevent it to be expanded. As we see here, first we book a stapler here, then makes a band here, then the food accumulated in the small pouch, so the patient can take a large amount of food, so he feels tired, then the food passes small by small. This is the modified anatomy. This is the normal anatomy of the case. So as we see, there is a small pouch, stapler line here, and there is a band here. The food come here, small pouch, so the patient feels satiety. But if she take any fibers or food, she will close this compartment, so the patient, as in this case, feel nauseated, heartburn, could increase the pressure inside the pouch, and also she can take a large amount of food. But our patient suddenly, she feel good, she can take more food. So what is the reason for this hair weight gain? For our case, sudden improvement of gastrointestinal symptoms with rapid weight gain and increase the volume of food intake suggested that the stapler line here will have a problem. So they refer for the gastroscopy. We see the gastroscopic. We think there is something here, fistula or something like this, which allows the food to come from the small pouch to the large stomach and do not allow him to pass through these narrow connections. Before we make the video work, we will see where we will enter from the stomach. In the normal case, we will see a pouch, a small pouch, stapler line here, and very small connections which connect the small pouch by the large pouch. We will see here, we enter the stomach. This is we must be here in the small pouch. Look here, this is the connection here, like that, and there is something here which is a fistula. Here, this means the stapler line contains large fistula. What we will do, we will enter from this fistula to see what is connected to. We will do like this. Now we enter from the fistula. They enter the large bowel, like here, and we reach the pylorus. We will pass this to shorten the case. Here we may maneuver. What we will see here, look with me. We see the opening from here like this, and we see the endoscope pass from the fistula down. There is a fistula in the stapler line which connects the small pouch by the large pouch, and this is the opening, the initial opening done, which is from here must pass all the food, but the food make a connections around the stapler line. What we will see there is the remaining of the stapler line. We again back to the pouch, which sees the fistula. How to manage? There is two management possible for this case. First is endoscopic, to close by over the scope clips, which close the fistula. But in our case, there is two problems to use this method. First, the patient have many complaints before, persistent vomiting, and severe heartburn means that the pouch is narrow and his opening is really narrow. So we shifted for surgical correction. What's the surgical correction? We'll convert this vertical band gastroplasty to another option which is called mini bypass surgery. He will separate all the stomach and take the pouch and contain it to the ileal bowel. So here the large bowel, here is the large stomach connected to the duodenum, to then here the efferent loop, and then connect the pouch here, and the food coming to the efferent loop to make efferent loop. And this is called mini gastric bypass. The patient do this operation and her symptoms improved and continue to lose weight. Thank you.
Thank you very much, Moataz. Any comments from experts? في صوت ايه يا جماعه؟
كلب.
Abeid, do you like to comment on this?
Professor Moataz, thank you for the excellent case demonstration. Have you tried the use of endoscopic suturing to diminish to decrease the size of anastomosis in those who have weight regain after bariatric surgery, especially the low and wide gastric bypass?
Really, the low and wide gastric bypass when it starts to gain weight, but it's not gain much weight. So we not really needed to to narrow the anastomosis. For this case, we not do the endoscopic procedure because the patient has complaining early from the small pouch and the small connections. So it is must be searching for another cause to improve her type of life.
I mean, if you have the large, you know, those who regain weight after the gastric bypass, they have a large stoma. The gastrointestinal anastomosis is
No,
large.
I don't interfere with. I don't have experience by another operation to not the OSD.
Very nice, Moataz, and we need more participation. We enjoyed very much your effort and presentation, and we'll move to my young colleague Younan. Younan, are you ready with your
yes, sir.
body removal?
Yes, sir. Good evening, everyone. Are you hearing me well?
Go ahead, Younan.
Okay, good evening, everyone. Great thanks, Professor Serag, for your kind invitation for me to be here. I will demonstrate a nice case for a young guy who accidentally swallowed a metallic nail. I will start sharing. Do you see the presentation right now?
Yes, yes, see.
Okay. 21-year-old male accidentally swallowed a metallic nail for 8 days. At the time of presentation, upper and lower GI endoscopies was done and nothing could be detected. CT was done and revealed that the metallic nail was detected at the ileocecal junction. For 8 days, the patient was received colonic preparation every day as a trial to push it down without any intervention, but all the trials failed. X-ray was done at the 8th day and the nail was still impacted. Colonoscopy was done until the terminal ileum and the nail was detected just beneath the ileocecal valve as shown in video number 1.
Yes.
Here I detected the nail. It's about 5 centimeter metallic nail, and in this hospital I didn't have over the scope, over the colonoscopy, or I didn't have foreign body holders through the colonoscope. Only I had only snare, and to use the snare for this very long way, I think it's a very risky procedure. This time I was thinking what will to do. Is a trial to take it out or for surgical exploration. But if we did surgical exploration, I think it will be very invasive. And I asked the relatives of the patient to just give him a trial to try to remove it by endoscopic maneuver. I tried in this moment to catch it by a snare. And I tried to take it from, my plan was to take the nail from the ileocecal junction till the splenic flexure. And then if I was succeed to get splenic flexure, I will switch it to the gastroscopy. So in the next video.
Yes, we see the next video.
Yes, it's played now. Here I was trying very gently to move from the ileocecal valve till the splenic flexure, about 20 minutes or more, but I summarized it in few seconds to show up. It was very risky. Any touch here or there, it may be result in a perforation.
You have to be very slow, of course.
Yes. And then when I reached the splenic fracture, I removed the micronoscope, and then I used a gastroscopy, but with cap over it, and I used the foreign body holder. But now I was quite secured to take it from the splenic fracture to outside. In third video, I will show it about in 2 minutes. I can, thanks God, to hold it inside the cap. And in this, I will try to put the sharp edge inside the cap to avoid more and more risk of perforation. Yes, now it's inside, and I start to withdraw very slowly. It was still very risky, about 3 centimeters outside the cap. Still the risk of perforation is very high, but
if we don't have the cap, we would like to hold it from the blunt end.
Yes.
And leave the tapered one away from.
Yeah, but thank God it was a cap, right?
So in the opinion of the audience, how long do you wait to expect that this nail can go out spontaneously? Let's say that he stayed for a week. Do we need to wait more because this nail passed all through the common site for obstruction, which is the cardia, as well as the pyloric ring and the ileocecal. So do you think wait and see could be an option in such case, or it's nice, it's a great maneuver to do, but do you wait further for spontaneous extrusion?
I think Ahmed Hashem should have told.
Yes,
I
exactly.
think this depends upon the type of the foreign body. If it is dangerous like this nail, or is it a coin, or a big key, etc.
I wouldn't wait.
We follow cases for more than months. Yeah.
Yes, and it can go spontaneously.
But to be honest, I wouldn't wait more than 2 days with such sharp, large object, because if it got impacted, it can do transfixation of the lumen. So I would interfere. I wouldn't wait longer than 2 days. What I would like to recommend in such cases, Younan, a very nice case, very stressful moments, you can use a glove, surgical glove. You can bend it on the tip of endoscope, invert it backwards, and when you catch the snare and the nail and withdraw it back, it will do like umbrella, and it should fill forward. That we did often before in Egypt. I miss these nails here in Germany, but in Egypt, in many cases we saw this.
You cannot do this in Germany.
I haven't seen once, but I mean, you can use always a glove, surgical glove, because it is thick enough. Do it like umbrella. Fix it on the tip of the scope. Withdraw it. And
stop sharing. Control. Stop sharing, please, Khalid.
This is one.
I think such a case arising a lot of memories to all endoscopists.
Of course.
And if you start to talk about removal of polymers, we have from up and down everywhere.
But Dr. Serag, you mentioned a very nice method also to hold it from the blunt tip.
Yes.
This is I think it is not dangerous if you hold it from the blunt tip and not very tight, and then you can withdraw. Oh, and nothing will happen. Don't worry about this. Nothing will happen. The colon is thick.
I think we
Serag.
passed through a lot of information tonight, and we kept you, Lars, too much by night. I'm sorry, but we are happy to have you with us.
Thank you.
Any more comments?
Dr. Serag.
Yes, Salem.
He could have used the gastroscope from the beginning and reach the cecum and remove this with the use of a gastroscope and
Enteroscope, you mean?
gastroscope. You can reach the cecum with a gastroscope.
And you use a gastroscope as a colonoscope.
Yes. And you put the cap, and it is easier.
What's the value? What's the value?
The value is less traumatic than using a colonoscope with the maneuver he is doing, because he first used the colonoscope and removed part of it, part of the needle. He removed it until he reached a certain part, and then he used the gastroscope. He should have used the gastroscope from the beginning. And if you're experienced enough, with a gastroscope, you can easily reach the cecum.
Any other comments?
I think it's a good comment. I think the literature is showing how often you can reach the cecum with a gastroscope. I think at best is about 75% or 80%, but I accept it can be different in expert hands. Anecdotally, someone might have 100%, but I think you're right, it is an option.
Yes, this is my comment as well, because it's not always easy in a colon, to reach the cecum in these cases. So it depends. If you don't reach it, then you have to do the same maneuver as our friend has done. Dr. Lars?
Yeah, I think, like Serag said, if you grab the blunt end of this with a snare, with a colonoscope, and pull it after you like that, that would be exactly the way this needle had gotten to the cecum, all the way from up in the mouth. So I'm sure that would be a very safe and very easy way, and you would have saved yourself a lot of time and effort and extra equipment.
Yeah, thank you.
Dr. Abeid, you have a question here from Iraq, Professor Nouri. You can open, Mohamed, the question and answer.
I agree with Abdelhafez that we cannot wait for such a sharp object.
I don't hear.
Like, I cannot wait for just a sharp nail for more than 2 days. I have to go and remove it.
Okay.
Right.
Okay, I think we had very nice talks tonight, and too much. I kept you posted. I'm very sorry, but thanks to Lars Aabakken about the cholangioscopy and dealing with the biliary analyticuli successfully and very up to date. And thanks to Mo for the EMR in the colon, and he promised to tell us about the limitation maybe next time. And thanks to Mohamed Abdelhafez, who's always presenting new courageous techniques, and Mohamed Abeid for the huge demo and dilemma of management of obesity and metabolic diseases. But I think, Mohamed, we should add diet regulation. Very important.
It's the first thing.
Stop eating too much. You will be like Lars Aabakken without any effort. And we thank our colleagues, Moataz and Younan, for these nice videos. I thank all of you, especially the commentators, Professor Ziad, Shariha, Salem Awad, and Ahmed Hashem, and all of you. Thank you, Lars, and I hope you accept our invitation again in other times, and good night for everyone and have a nice day. Bye-bye. And of course, we have to thank Asino, who hosted our meeting. We thanked at the beginning and we thank at the end. We thank Parcode for the arrangement and everything. And thank you.